Good evening, sir. Thank you.
Kulkarni sir.
Good evening,
Anand,
everyone.
Pankaj, yeah.
Good evening. Good evening.
Good evening.
Shirish sir. Shirish sir has joined. Yes.
Yeah, he's joined, sir.
नहीं,
So we are
yes,
live.
sir. Okay.
विरल मेरी आवाज आ रही है क्या?
Yes, sir.
Yes, sir.
Rahul, you can start. We are live.
Yes, sir. So, good evening, everyone.
Sir has joined. Thora sir has joined. Yeah.
On behalf of Vidarbha Ophthalmic Society, I extend a very warm welcome to all of you for this special academic evening. It is an inaugural session of the VOS Wednesday Webinar. So this is an initiative which is a humble effort from the team VOS to create a platform for regular, meaningful academic exchanges in collaboration with various district ophthalmic societies and eminent national and international faculties. The aim is simple: to stay connected, updated, and inspired through the focused, high-valued discussions. We are pleased that this our first session we are doing in collaboration with Ocular Academy of Ophthalmology, and we are truly grateful for all of your presence. We are today privileged to have one of India's most respected cornea specialists with us, Dr. Somshila Murthy Madam and Dr. Rishi Swarup sir. We are also grateful to our esteemed panelists, chairpersons for their presence. Now to officially open the session, I request our respected President, Vidarbha Ophthalmic Society, Dr. Viral Shah sir, to share few words to address the gathering. Over to you, sir.
Thank you, Rahul. Good evening, everyone. It is my great pleasure to welcome you all for the first edition of this VOS Wednesday Webinar series, commemorating 50 glorious years of Vidarbha Ophthalmic Society, a golden milestone in our journey of academic excellence, professional unity, and unwavering commitment to the eye care. This evening session on ocular, surface, and refractive surgery brings together some of the most respected and eminent names in the field, both nationally and from within our own vibrant VOS community. I extend my heartfelt thanks to our esteemed speakers, Dr. Somshila Madam, Dr. Rishi Swarup, Dr. Shirish Thorat, and Dr. Anupam Bagdi for sparing their valuable time with us. And I welcome our chairpersons, Dr. Deepak Nilawar sir, Dr. Nitin Upadhyay sir, and Dr. Vinod Dattakia sir, the session moderators, Dr. Anand Pasari and Dr. Pankaj Lande, and our esteemed panelists, Dr. Ajay Kulkarni sir, Dr. Subodh Purohit, Dr. Saurabh Munra, Dr. Prabhat Nangya, Dr. Kavita Dangra, and Dr. Neha Rati. The theme of this webinar, honoring the past and shaping the future, which is our theme for the whole year, perfectly reflects our intent to draw strength from our rich legacy while embracing innovations that will guide the future of ophthalmology. I congratulate the scientific committee led by Dr. Rahul Tiwari and Vice Chairman Dr. Neha Deshpande and the entire scientific committee of VOS for bringing together this collaborative efforts along with Ocular Academy of Ophthalmology for curating this meaningful academic excellence. I also welcome the President of Ocular Academy of Ophthalmology, Dr. Pradeep Agrawal, and Secretary Dr. Sanket Deshmukh and Dr. Nishant Rathi for the webinar. And special thanks to Dr. Shirish Thorat sir, who is also the President of Maharashtra Ophthalmic Society and immediate past President of Vidarbha Ophthalmic Society, to spare time for and preparing the presentation for our Vidarbha Ophthalmic Society. Thank you, sir. So wishing you all the fruitful and engaging session ahead. I hand over the proceedings to Dr. Rahul Tiwari. Thank you.
Thank you, sir. So today we have a dynamic duo of two young cornea specialists, Dr. Pankaj Lande and Dr. Anand Pasari, who will moderate the session. And without wasting further time, I hand over to moderators to conduct the further session. Over to you, Pankaj and Anand.
Thank you very much, Dr. Rahul sir. So without wasting much time, we would have our first esteemed speaker, Dr. Somshila Murthy Madam. Somshila Murthy Madam doesn't need any introduction. She is also known as Dr. SS amongst her fellows and in the LVPA Cornea Fraternity. She is currently the medical director of Shantilal Sanghvi Eye Institute, Mumbai. She is a specialist in cornea, anti-segment disease, and cataract and refractive surgery. Her main areas of research are cornea, uveitis, and inflammation. She has more than 200 scientific publications. She has given more than 200 scientific talks in national and international levels. She is also a member of scientific committee for All India Ophthalmic Society. So without wasting much time, I'd hand over to Dr. Somshila Murthy Madam for her talk. She would talk on enlighten us or the topic of allergy for general ophthalmologist, learning through cases. Over to you, Dr. SS.
Thank you very much, Anand. Such a pleasure to hear from you. Am I audible? And is my
Yes, madam. Yeah,
Yes.
it's perfect, madam. Perfect.
At the onset, I would first of all like to congratulate Vidarbha Ophthalmology Society and Ocular Ophthalmology Society for putting together this series of webinars, which is the first of many, hopefully. And I would also like to thank Dr. Viral Shah, Dr. Rahul Tiwari, and of course, Dr. Neha Deshpande, who have given me this opportunity. And honestly, when you first said that this session will be moderated by our young cornea specialist, I thought you'd mention my name. Then I realized I'm no longer young. I'm pretty old, and that's for me. But Rishi, you're also not included in that, so that is sad. So anyway, the generation has to go to the youngsters. So initially, I thought of directing it towards a general ophthalmologist, but I realized that the society has many members who are beyond just general ophthalmologists, a lot of specialists. So I'm going to keep it at a level of sort of specialist level so that the general ophthalmologist also will be interested. And I thought I'll keep it simple and so we can learn through cases in the next 12 minutes. So we all know, need not be reminded that hypersensitivity in patients, that is what we see in most of our patients with allergy, especially with the severe kind of forms of allergy. And it's very common. It affects maybe in Western literature, it says 20 to 25% of population. It may be slightly less in Indian literature, but in terms of sheer volume of patients, because our population is huge, we do see huge amount of patients who presented allergy, ranging from mild to extremely severe. So the mild forms is what you see the picture at the top. So the patient has just something called seasonal allergic conjunctivitis, which is or hay fever. And, they have this condition which is easy to treat and doesn't leave any lasting sequelae in the eye. Whereas the other pictures you have, the patient with the corneal scar. So that is a patient who has atopic keratoconjunctivitis. And the other three pictures you can see on your right is a patient with VKC, the limbal form, and then you also have a patient with the giant papillary conjunctivitis, which literally is a hallmark of VKC for patients with allergy. So though we explain to the patients when they come to us, because many of them are pediatric patients, the parents bring them, and we do explain saying that this will disappear as the child grows up. And we do see that a large majority of patients, the allergy sort of wanes away or gently goes out into the background once the child achieves puberty or in the late teens. But I'm sure many of you, especially in the Vidarbha belt, because it's a very hot area, will see patients where they have persistent allergy even in adulthood. So I thought I'll present a few such cases and what we do with them with these kind of cases, because maybe you might be seeing such severe cases which are difficult to manage. The mild cases, I'm sure most of you manage with the use of mast cell stabilizers, lubricants, and at best low-dose topical steroids. And these patients get better. But what do you do for the severe cases, which is what my talk is about? So the first case I have is a 22-year-old, and I'm showing you his skin pigmentation, hyperpigmentation. It's very pathognomic of atopic dermatitis, and he's had this since his age of 2 years. As you know, this is an autosomal recessive condition, which there's really no cures as such for it. And it is immune mediated, so the patient has to be on immunosuppressants. So this patient was on methotrexate for many years. He had also received cyclosporin, oral cyclosporin for a few years, but that was discontinued because his systemic part, his skin was under control with methotrexate. But that was not enough to control his eye disease. He continued to have VKC beyond his childhood years. And when he presented to us, his vision was 20/100 in the right eye, 20/40 left eye. And he continued to have a lot of symptoms in the right eye. He had shield ulcer in the past, which we managed. So for this particular patient who presents with systemic disease also, whether it's atopy or some patients can have chronic systemic allergies like rhinitis and so on. So there's no point trying to treat the patient with mild therapy. In these patients, most of us now tend to use oral immunomodulators. For example, we can use oral lower dose steroids, and we always use topical tacrolimus in most of these cases. And also, of late, we've been adding oral cyclosporin to get good control. So with this, we added oral cyclosporin. We continued the topical therapy. He's already on steroids. And subsequently, the patient is better, but he still needs continuous monitoring. So this is the same patient where you can see why his vision is poorer in the right eye. That's because of this flower dusting or this stippling on the cornea, which is typical of VKC patients. He also has the changes in the limbal region. And this is the papillae that he has. So it's very classic. The right eye was worse and the left eye was slightly better. So these giant papillae, the cobblestone papillae, these are the ones that keep rubbing even mechanically on the cornea, resulting in that particular surface problem. Coming to the second case, so what can we do for these papillae if they continue despite all treatment? So this was a 16-year-old and he had VKC since age 12. And in between, he had very severe allergic episodes where his eye would continuously be itchy and he couldn't even go to school, and he would present to us with recurrent shield ulcers. So slowly the child, because of the problem, he was unable to perform well. He had fallen behind in school and he was going into depression. And what we saw was both eyes was this cobblestone papillae. In the right eye, he also had a shield ulcer. So we had tried a lot of therapy for him, especially steroids. So we first, again, for this particular episode, we may control it with topical steroids. And because we were running out of options and we realized that the giant papillae were rubbing the cornea, so in this patient, this was a few years ago, we decided to do a gentle surgical excision, and we applied a double layer amniotic membrane on the bare surface once we removed the papillae, and we also gave a supratarsal steroid injection. Post-op, we're managing this young adult with topical low-dose oral steroids and tacrolimus eye ointment. He still has mild reactivation. So since then he could complete, at least he went into college, completed his engineering studies. And I've been following up this patient for about almost 10 years now. He continues to have allergy, but the cobblestone papillae have not reappeared. So that is one good thing. Coming to another case, which we have been managing in Mumbai, and my colleague, Dr. Supriya Sharma, took care of this patient. So this is a 15-year-old male, and he, of course, has severe itching and photophobia, eye rubbing. For 4 years, he has drooping of both lids for 2 years, and now he is complaining of right eye drop in vision since the past 1 year. When he came to us, he was already on mast cell stabilizers, topical lubricants, low-dose steroids, and tacrolimus eye ointment, which he would use when he had a lot of symptoms, but otherwise he really felt it didn't help him much. So his past interventions were that he had received 3 subtarsal steroid injections. He had already undergone surgical excision of the papillae twice, actually. And then he had undergone surgical excision with AMG application also twice. So now what do we do for this patient? So this is the appearance of this patient. He still continued to have these cobblestone papillae in both the eyes, and they looked. So one more way to make out if they are active or inactive is to apply fluorescein stain. Though here you can definitely see it's very congested and active. But with fluorescein stain, you see that the apex of the papillae also pick up the stain. So that's what happened here. I don't have those pictures. So the options are, shall we again give supratarsal steroids, or just step up the oral and topical steroids, or add some systemic immunomodulator therapy? What should we do? So we did a combination of everything. So we started the patients on high dose of oral steroids, and then we added cyclosporin. Of course, all of this is with a collaboration with a physician. We get the baseline workup done for the patient, rule out any other concurrent infections. So this is not something that we just prescribe, but we make sure with due diligence that we prescribe these medications. So this is even after starting all treatment. If you look at the cobblestones, they still look fairly active. And then when you apply fluorescein, that top part of the cobblestone still erode the cornea and make it stain. So finally, we decided to go ahead and do, this is a technique which has been published by the Shankar Nitrale group, where they use the oral mucosal membrane. So we did that. We excised the papillae and applied oral mucosal membrane grafts. And luckily, the patient is doing well. This is 2 weeks post-op, and this is about 3 months post-op for the patient. His symptoms have definitely subsided, and we are following up this patient. Eye looks much quieter. That was 8 months post-op, sorry. So shield ulcers, I was mentioning, but that is something that occurs fairly frequently in such severe cases. And what we need to do for shield ulcer is depending on its grade. It is one of the indications where you need to use aggressively topical steroids, but make sure that the patient does not have a concurrent infection. For example, this patient, who was a child actually, she was 8 years old and she had shield ulcer along with corneal infiltrates. So she had severe allergy in both eyes. So we performed corneal scrapings and sent for microbiology, which revealed infection with bacteria. Luckily, she improved with topical antibiotics. Subsequently, we went on to apply an amniotic membrane, and the ulcer scarred. We can see with keratoconus, I'm sure something that many of you must have seen. And in these cases, because of the continuous eye rubbing, the patients can present early with eye drops. There was one such patient who had advanced keratoconus and presented to us with eye drops. This is the ASOCT showing the large amount of fluid. What we did for this patient is that we had to do desmetopexy twice actually for this child, because the first time we did there was really no change, and this is the second time. So literally you can see that we made a tab incision, massaged out all the fluid from the interface, and finally we injected a full chamber air bubble. We performed a peripheral iridectomy, and after this quite an extensive sort of removal of fluid from the interface, the patient did well and finally progressed to a corneal scar with about 20/60 vision with a scleral lens. So, but however, if I take up the same case off late, I would definitely use compression sutures, because we can have a much rapid resolution of the Desmet's detachment, or of the large amount of fluid that is there when you use these sutures. And we have published these results of compression sutures, planned compression sutures in these cases. And I'll end off with steroid-induced complications, cataract, which is fairly frequent. Cataract surgery may not be very difficult, except that in this case, you can see that the limbus is so extensively affected. So whichever place you select, you have to suture that at the end of surgery. We could do a phaco because, as you know, these are young patients and they have soft cataract. Only problem is that the IOL power calculation. So that because the cornea is extremely steep, don't go with the IOL power calculated just by keratometry, but use the oculizer to calculate the IOL. So you can get a fairly good result despite such steep corneas and such advanced, almost like a partial limbal stem cell deficiency in these cases. So I hope these cases were demonstrative of how severe VKC can be, and how we can approach these conditions in severe VKC. So once again, I want to thank everyone for giving me this opportunity. And since Vidarbh is, you're not very far off, so please do come and visit us in Mumbai. And we have a beautiful center, and we look forward to seeing you here. Thank you.
That was a wonderful presentation, ma'am, through cases and complex case scenarios. Maybe it was a bit more for general ophthalmologists, but for sure it was useful for us what kind of cases we see, but very enlightening and newer modalities into. Next, we would invite Dr. Shirish Thorat, sir. Dr. Pankaj, sir, I would request you to introduce Dr. Shirish Thorat.
Thank you, Anand. That was a wonderful talk, ma'am. Thank you so much. The questions about the talk we will take at the end. We'll introduce now very own Dr. Shirish Thorat, who is a general ophthalmologist practicing in Ocular, and is a very known personality. He is currently holding the post at MOS, and is having a private practice at Ocular. So here we start basics of refractive procedures. Sorry.
Pankaj, are my slides visible?
Yes, sir. Your slides are visible. You can proceed, sir.
It's not coming on my screen.
We can see it well.
You can stop sharing and reshare again.
Stop sharing, reshare.
Sunil, you can help. Sir, go to the top
It's
arrow
visible.
from beginning at the top.
Yes.
Yeah. Now you can see.
My screen is blank.
Okay.
Sorry. I'll start
Okay,
again.
shall we make one arrangement that let Anupam present first?
Okay. Now you can see, sir. Now you can start sharing screen from below.
Right lower corner, sir.
No, screen is off.
Mr. Sunil, are you there?
Your slides are visible to us, sir, now.
It's not coming on a full screen.
Full screen from the bottom you can do, sir. From the bottom. Near the volume button.
That near magnification button, you can see one round
Yeah,
with
that
that
button.
small
Yeah,
arrow
that button.
down. Yes, yes, sir.
Yes. Click it. Double click.
Yes.
Play the next slide, sir. Next slide.
नहीं क्या ठीक है
My
Sunil.
yes sir.
We can see Dr. Shirish Thora's slide, but he is not able to see when he starts the slideshow at his computer.
सर आप कौन सी डिवाइस पे हैं?
laptop.
हाँ एक बार जरा दोबारा करिएगा. Just make it full slide. एक बार स्लाइड शेयर में डाल दीजिए एक बार.
From beginning.
हाँ जी. Either on the top from beginning.
From current slides.
सर एक बार हाँ एक बार अभी आ रहा है. बिल्कुल आ रहा है सर. आप एक बार टॉप पे ले जाइए.
आपको दिख रहा सर?
मुझे दिख रहा है लेकिन फुल स्क्रीन नहीं आ रहा है. हाँ अभी आ गया.
तो
अभी सर अभी हाँ अभी फर्स्ट क्लास एकदम ठीक सर.
ओके आ गया.
यस सर परफेक्ट.
ओके sorry for the technical please. At outset let me thank Dr. Viren and Dr. Rahul and team of VOS for the opportunity. The topic given to me by Dr. Rahul is the basics of refractive procedures for general ophthalmologists for beginners. So basically there are different types of refractive procedures. Some like corneal based procedures like PRK, trans-PRK, LASIK, SMILE, and lenticular based like Fiki-Kaur or RLE. Patient selection criteria one must follow rigorously. On examination, the age of the patient, refraction, all ocular conditions should be assessed, and investigations, the pachymetry, keratometry, tomography, and Sharma test is most important. What are patient selection criteria? The cornea should be healthy. There should not be any pathological cornea. There should not be ulcer. There should not be any opacities and all. Age of the patient should be about 20 years. So we are following 21 years, and refraction should be stable for at least last 9 to 12 months. The retina should be healthy, and there should be no ocular comorbidities associated. What are the contraindications? Any corneal pathologies, any disease like diabetes, thyroid, pregnancy, autoimmune disorders. Steroids and retinoic acid treatment will hamper the healings. Any other ocular comorbidities like MGD and all, and unrealistic patient expectations should be contraindications for these procedures. Going to the corneal thickness on the tomography. Before tomography, always ask for the history of the contact lens wear because to avoid the contact lens warpage readings. So we're following that corneal thickness should be more than 470 for a surface ablation, and for LASIK it should be more than 50 micron. Because every diopter of correction, it was corneal tissue will get lost by 12 to 15 micron. So safe residual stroma build should be 300 microns. What is the importance of K values? Ideal K values should be 42 to 47 for the flap procedures. And every correction of the one diopter, it will decrease 0.8 to 0.9 in the K values. So the post-LASIK K value should not be less than 35. So K value, if very flat, there are chances of free flap, and K values, if they are very steep, the chances of buttonholing. So it is better to go for PRK for too steep or too flat corneas. So 42 to 47 is a range for the flap, what we have kept in our center, and below and above that, according to the refractive error, we are doing the surface ablation. White to white is important because while doing flaps, the nomogram is created for the microkeratome. Like in this case, on left hand side, it is 43. Suppose the horizontal K is 43. They have given three choice for this. What side of ring is used and what side of stop should be used. So for white to white less than 11, so use the highest ring. White to white in between 11 to 12, choose the middle one, that is the best. And white to white, more than 12, you should take the lowest one. This is white to white for 43, and you should take the middle one, which is for 11 to 12. To simplify the interpretation or in our general ophthalmology OPD, the rough calculation is for each diopter of ablation, the depth we are losing is 10 microns. So residual stromal bed, the safety margin we are keeping like 280 to 300. So residual stromal bed is equal to central corneal thickness minus ablation depth plus flap size. If 90 or 110 microkeratome used, so residual bed is 330 after calculating all that. So minus 6 can safely be corrected. Likewise, in the keratometry, for rough calculation, for each diopter of correction, K value is decreased by one diopter. So minimum residual K should not go below 35. So if patient is of the keratometry of the patient is 42, so 42 minus 6 is equal to 36. So minus 6 can be safely corrected. In all, if you don't have any Wi-Fi instruments, just deduct 400 from the pachymetry. Like if you have a 500 of central corneal thickness and minus 400, you will get 100 micron to play with. So 100 divided by 12 or 15, that is the dioptric power you can safely remove. So this is another formula for percentage tissue ablation. Though it is look complicated, it is very simple once you get into that. So this percentage tissue alteration should not be less than 40 degree for any type of surface. Going to the PRK, it is a very good process. Surface ablation is a good procedure because there are some advantages like 4470 package acceptable. It is safe too steep and too flat corneas. It is for better mic stability and less learning curve. There are certain disadvantages, like early days post-operative pain is there, and comparatively a long recovery period, which you should uh, convince the patient beforehand. So, like in this case scenario, the pachymetry is low. Though the keratometry is good, pachymetry is low. This is the case for a PRK, surface ablation. Like in this case, pachymetry is very good, but keratometry doesn't allow us to take a flap. So, um, in this case also the surface ablation is better. This is just a small video of trans PRK. After setting and doing a cyclotorsion and alignment, this is a trans PRK. The machine itself is doing epithelial removal, and after the laser, this is a mitomycin C which we are filling over the ablated bed. This is a very good technique Dr. Ajay has taught me. Earlier we were using the sponges. After removal, after this thing, remove the mitomycin C and thorough wash is given. Roughly around 20 to 30 ml of saline and bandage contact lens is applied. Going to the LASIK, there are certain disadvantages of LASIK. That is, wow, if it is there, no haze, no pain, early recovery is possible. This is a femtoflap with a hinge on. But there are certain disadvantages of LASIK, like pachymetry is needed more than 500. K values should be between 40 to 47 to avoid the complications. And biomechanical stability and dryness is certain issue. These are also case of LASIK. Like in this case, this is refraction index 6.25. Pachymetry is good. Keratometry is good. So large area. So I avoided this type of correction with the PRK just to prevent the haze. This is a LASIK flap by microkeratome. After the marking, before taking the flaps to final realignment, the marking is done. The precise size of microkeratome and ring size is applied. Cut, wet, and after dry. So this is microkeratome creating the flap. Flap is lifted. We need to protect the flap and the hinge to prevent damage by the laser. Laser is getting done. After the laser, a wash is given to the interface. After reposition of the flap, and the ironing and realignment with the marking is done and BCL is applied. So most advanced is lenticular extraction. There are certain advantages and disadvantages of that. Certainly, wow, if it is there, no haze, and there are no flap complications, no pain, and less dryness. And biomechanical stability is certainly a more than a flap procedures. But there are different disadvantages, like it has got a learning curve and is a slightly costly procedure as machine-wise. So this lenticle is removed and the process is done. So going for the refractive laser is a patient decision. It is not surgeon which is forcing for the patients. Good counseling regarding post-operative expectations. Choose the right procedure for the right patients. Post-op residual stroma should be more than 280 to 300, and post-op K value should not be less than 34 to 35. Under promise and over deliver is the key to the patient satisfaction. Going to lens-based procedure. Suppose this patient with a high refractive error with low Pachy and keratometry is not suitable for any type of the corneal-based procedure. So ICL, IPCL, or any type of the lens-based procedures are indicated. In these cases, anti-chamber depth from corneal endothelium, white to white measurement, and pupillary size. These are the things we should be consider. It is internal ACD, which is very important. We should not be less than 2.8 to 3 millimeter. I just show a video of how to take the white to white measurement. So with the dialer, I'm marking the two ends horizontally. It is actually the white to white where the black portion of the iris end, that is HVID, actually it is a horizontal visible iris diameter. And you should just align two corners of the measuring cylinder. And you should take around 6 to 7 different readings to get white to white with a calibrated caliper. This is just a short video of IPCL. You should not feel the visco too much. There are certain guidelines by the company which side is up, which side is down in ICL and IPCL also. You can put all the haptics on the iris itself and then tuck into below the iris. With the practice, you can tuck all the haptics in the first go itself, and visco should be removed. The vaulting is very important because high vault can cause angle closure, low vault can cause lens changes. So this is OCT showing the vaulting is 431 after 3 months of same patient, and it is, I mean, following the good range. The ideal size of IPCL vault should provide a vault within the range of 1/2 to 1.5 corneal thickness. This is how you should assess the vault on the slit lamp. This is anterior chamber, and this is a vaulting. And just compare this with the corneal thickness. You can easily make out vault on the slit lamp itself. So, as I said, it is a patient choice, but at the same time, I'm saying that it should not be the surgeon who should fulfill every time the surgeon's patient's wish. This is a patient with a minus 14, 15 diopter. He underwent RK surgery in 1998. Then he undergone LASIK in 2004. Then undergone second refractive laser for residual in 2008. Then for IPCL corrected IPCL at the age of 32. Now he came to me for a cataract surgery. So a single patient has given experience of RK, PRK, LASIK, IPCL, everything, and now he is undergoing cataract surgery. So with a scleral incision, I have done his cataract surgery. Three-piece IOL is implanted. And now he is behind me to close this hole because of the glare and halos. But luckily, after 3 months, the anticapsular fibrosis has taken care of his glare and halos. So this is a final refraction of the same patient. So friends, for IPCLs, load and insert the phakic IOLs as per the company guidelines. Manipulate the haptic elegantly. Do not touch the optics. Do proper removal of viscoelastic. Post-op follow-up is important. Always look for IOP and vault measurement. Thank you. This is what I have prepared in short. Thank you all.
That was really beautiful presentation, sir. And the last case which was shown by you is extraordinary, and the amount of stress while handling such case is very high. Just I have one question, that how you manage the IOM calculation power in such scenario?
Almost 99% of the cases, I shifted my all formulas to the Barrack Turret or Barrack 2. So this is after calculating all the formulas, I went ahead with blindly with the Barrett Toric, and I landed with the points plus 0.5 square and plus 0.75 square.
Right. Okay. Thank you. I will hand over to Dr. Anand Pasari to introduce Dr. Anand, Dr. Bagdi, please, so that we can have a next talk.
It's my pleasure to introduce my dear friend, Dr. Anupam Bagdi. To introduce Dr. Anupam Bagdi, graduated from BYL Nair Hospital, Mumbai, and then did his DNB and long-term cornea fellowship at LV Prasad Eye Institute, Hyderabad. He was one of the first to start cornea transplant center in Eastern Vidarbha, and now he has his own setup, Suraj Super Specialty Eye Hospital, since 2018. Anupam.
Am I audible?
Yes, Anupam, you're audible.
Okay. Thank you, Dr. Anand, for your kind words of introduction, and a very good evening to all of you. It seems with Dr. Somshila and Dr. Anand around, it seems like a Friday subspecialty class going on, and it invokes many memories from our LVP days. So without further ado, let me start with my topic. I would like to thank Team VOS for giving me this wonderful opportunity. I would be speaking on 5 mistakes to avoid when dealing with chemical injuries. So before we start, we all know that we are well aware that after we have to give a thorough wash to the patient, and litmus paper tests and everything. For alkali injuries are more are worse than acid injuries, and so on and so forth. So I've just selected 5 very specific points today to share with you all. From my experience, what I have seen when the patient gets referred to us, what better things could have been done before they have reached us. As from those experiences, I'm sharing just 5 of my clinical nuggets which I want to drive across. Yeah.
Dr. Anupam,
So, yeah.
your voice is slightly breaking. Can you just make it slightly better if you can?
1 second.
Yeah.
Is it audible now?
Yeah, this is better now, Anupam.
Is it audible now?
Yes, yes.
Yes, yes.
This is better.
Maybe I'll try to speak a little louder. Will that
Yes.
be okay?
Yes, this is enough. This is enough.
Okay. All right. So I will straight away jump to my first point here, which I want to highlight, and that will be a lot of patients, a lot of the general ophthalmologists or the primary care givers do not use fluorescein stain to evaluate chemical injuries. It's a blunder because fluorescein is the marker which will tell you how much of the epithelium has been lost because of the chemical.
Anupam, your voice is not coming clear. I think there is some problem with your. If you come closer to your device, and you can shut off your video.
Okay.
I think you can use the audio of your
Bluetooth.
laptop directly. You can skip the earphones.
Okay. Let me try that.
You can just shut off your video and go on with your microphone or your Bluetooth. Yeah.
Okay.
Now
So is it making any difference now?
Yes,
Yeah,
definitely.
it's more clear now.
Okay. All right. So not using fluorescein is one of the blunders that we can do while evaluating chemical injury. One of the main reasons I am calling this a blunder because a lot of times the patient will have an eye which will not obviously look like a severely damaged eye, but it will have a definite worsening when you check with fluorescein. For example, this 10-year-old female who had come with bilateral skin injury. So when you see both the eyes appear to be very similar, then we saw just on plain slit lamp. But when you stain this with fluorescein, you will exactly see the extent of epithelium that is defective in both the eyes. And as we go ahead in the presentation, you will come to know why this will make a difference in your choices for treatment, in further options of treatment for each and every patient. So please do not forget to stain the patients with chemical injury with fluorescein. Check how much of the epithelium is actually denuded. Second thing here is if you have a patient, for example, who has a clinical picture like this, so you will not be sure without staining how much of the epithelium is intact, whether it has a defect or not, because there is no specific defect that is seen on the cornea right now. But if you stain this with fluorescein, you will notice that not just the whole of cornea, but almost 90% of conjunctiva is also suffering from an epithelial defect, and this is a grade 6 chemical injury which needs immediate surgical management also with amniotic membrane. So if you would have just looked at this clinical picture thinking that, oh, probably the epithelium of the cornea is intact, then you would have missed a very, very big clinical picture of such a huge epithelial defect. So sometimes for staining such huge epithelial defects, just a gentle touch with fluorescein strip may not be sufficient. You have to literally paint the surface with fluorescein to make these epithelial defects visible. And needless to say that these patients are very symptomatic when we are assessing them. So do put a drop of proparacaine hydrochloride drops so that the patient becomes comfortable for assessment. Along with fluorescein staining, we should also check the furnaces for any remnant chemicals, anatomical integrity. Like for example, long-standing chemicals may erode the cornea and lead to some kind of perforation sometimes. And also, we have to rule out infection in such cases. Based on the epithelium that is involved or the defect that is involved, we have many classifications. Earlier, Roper-Hall classification was being used, and now lately we have been following the VOS classification, which includes the number of flock hours of limbus which is involved and percentage of conjunctiva that is involved. It also helps us to prognosticate the case and decide for whether we have to go for surgical or medical management. So, for example, if you want to grade grade the patients based on the extreme. Sorry, one second. Some screen has cropped up. Yeah, thank you. So based on the classification system given by Dr. Harminder Dua, we have classified these defects into from grade 1 to grade 6, where grade 1 is just a small defect which is limited to the cornea, and grade 6 is where more than all 12 clock hours of the cornea is involved, and more than 90% of the conjunctiva also is defect. So the second mistake that we make here is, we, even after classifying, sometimes we try to treat the severe form of chemical injury also medically. That mistake should be avoided, because now, based on the prognostication criteria, we already know that grade 4 to grade 6 are supposed to be taken up for some kind of surgical intervention, be it amniotic membrane grafting, be it tarsorrhaphy or tenonplasty, or stuff like that. So make sure that we classify the amount of defect correctly, and then also we take a decision regarding which defect has to be treated with amniotic membrane, and which defect can be treated just on medical therapy. So the aim of any therapy in acute chemical injury is to save the eye, and we need to make sure that we explain this to the patient also. And the main two aims are to promote the reepithelialization of the surface, be it corneal or conjunctival. This means that even if a huge grade 5 or grade 6 chemical injury heals with conjunctivalization on the cornea, we are still happy with it, because we have prevented the melt of the stroma and given a protective covering to the surface, even in the form of conjunctiva. Okay, because we can deal with it in a later stage. And also we have to prevent the deepithelized stroma from melting. So temporary and permanent, both covers have to be given to the stroma in order to save the eye. So when we come to medical therapy, there are multiple options that we have to control inflammation. We have corticosteroids, we have vitamin C supplements, we have artificial tears, we have bandage contact lenses. But sometimes the mistake that we make here is we forget the role of corticosteroids. When we see a large epithelial defect, it has been ingrained into our minds that with a nude stroma in front of you, avoid putting corticosteroids to avoid melt of collagen and collagenolisis. But believe me, this is one of the biggest mistakes we will be making if we do not start the patients of chemical injury on corticosteroids, because corticosteroids form one of the real mainstays in the medical management of these injuries. So be sure that you don't hesitate in starting corticosteroids for even larger defects, even grade 6 injuries. In addition to surgical therapy, corticosteroids are a must. So as we have seen, the surgical decision making of grade 4, grade 5 and grade 6 chemical injuries can be in the form of amniotic membrane or tenonplasty or tarsorrhaphy. Let us throw some light on that. So when in the acute setting you try to manage, it's important to debride completely the necrotic tissue and proximate a source of epithelium for the denuded corneal surface. Also, it's better if you can establish the limbal vascularity to prevent anterior segment necrosis. So when you see this kind of picture, the superior tenons and the superior conjunctival space, this is all avascular and necrotic. And when we deal with such cases, we have to excise these parts and then cover it with an amniotic membrane. Amniotic membrane is a wonderful tool in the hands of corneal surgeons and others, because it has multiple roles, like it does potential to anti-inflammatory properties, anti-fibrotic and anti-neovascular properties. An example of how we do chemical amniotic membrane transplant in chemical injury, that first we do a 360-degree peritomy, and after completely dissecting conjunctiva and making space for the amniotic membrane, place the amniotic membrane as a whole. We secure the amniotic membrane after trimming the amniotic membrane. We secure the amniotic membrane in place using fibrin glue, and in most of the cases, we would do central tarsorrhaphy with this procedure. This is for acute setting, and We will see more details about it. Tenonplasty and tarsorrhaphy are supplementary procedures which can be done alongside. And here I come to mistake number 4. So you would say that you have done medical management, you have done surgical management. अब बचा क्या है भाई? What's mistake number 4? So वही मैं कहने जा रहा हूँ क्योंकि पिक्चर अभी बाकी है मेरे दोस्त. ये आपके लिए नहीं, ये हमें कहना है पेशेंट के लिए कि भाई पिक्चर अभी बाकी है. That means you have to make sure you counsel the patient perfectly, because indeed the picture is still left. It was just a trailer. What they have seen is just the acute setting. In most of the cases of grade 5 and grade 6 chemical injuries, they will land up in some form of limbal stem cell deficiency and conjunctivalization or symblepharon and so forth. So we have to make sure in the beginning itself, you have to tell the patient that this might need multiple operative procedures for visual rehabilitation, and just one procedure may not be sufficient to completely treat the condition. Very important to tell it beforehand, to give a rough timeline to the patient about how things might look ahead and how many months you may need to plan a second procedure, how the outcomes of the first procedure may look. So very important that do not shy away from spending some extra care time with the patient and telling them exactly how the sequence of events might turn out to be. So once you have treated the chemical injury in the acute phase, the patient might successfully land up in LSCD. Why I'm saying is that because you have, even after a severe chemical injury, you have saved the surface and covered it with conjunctiva, it is still a good success. When you have limbal stem cell deficiency, the fifth mistake that sometimes we make as general ophthalmologists or primary caregivers is, when you see such kind of corneas, we just write it off. We just tell the patient, oh, it's a very severely damaged cornea, nothing can be done. Please, please, please do not make this mistake. Do not write such corneas off, because now we have wonderful techniques to deal with such situations also in the form of limbal stem cell transplantation. And one of the procedures that we have for advanced stage unilateral procedures is the simple limbal epithelial transplant. We have been practicing since quite some time now. It was first described by Dr. Sangwan from LV group, and it's a wonderful technique where we take just one clocar of limbus from the normal eye, and we cut it into small pieces, place it on cornea after Panner's dissection, and then slowly the limbal stem cells populate their corresponding areas and form a well epithelialized surface. So this is the example which we had seen earlier in the presentation, which had a grade 6 chemical injury with the complete surface being denuded of epithelium. It turned out to, after amniotic membrane transplantation and tarsorrhaphy, when we opened tarsorrhaphy after 3 months, the surface was well epithelialized, although with a vascularized panacea. And when you look at this result, we have been able to achieve such a result with simple limbal epithelial transplantation. So please do not write away corneas which look severely damaged. They might just be having a conjunctival layer on the crystal clear cornea, which can be relatively easily taken care of. We also have options for bilateral deficiencies, bilateral limbal stem cell deficiencies in the form of keratoprosthesis and limbal stem cell transplantations. So what I mean to say is, even in bilateral severe cases, there is something we can do for the patient. So just to sum up the presentation, do not write off bad corneas with bad surface. There is something for everyone. Amniotic membrane and steroids are very important in management of acute chemical injury, and we should know the indications and contraindications of both these things when dealing with chemical injury. And procedures like simple limbal epithelial transplant have taken care to the next level and have helped us give wonderful results to even severely damaged eyes. Thank you.
That was a wonderful presentation, Dr. Anupam. In the interest of time, last talk, which is of interest to everybody, that is on refractive session. I would ask Dr. Lande sir to introduce our national faculty, Dr. Rishi Swarup sir.
We are fortunate today to have Dr. Rishi Swarup sir, who is one of the very pioneering ophthalmologists from Hyderabad. He is a medical director and chief surgeon at Swarupa Eye Center, Hyderabad. He has done his MBBS from Kasturba Medical College, Manipal, and diploma in ophthalmology from CMC Vellore, followed by a long-term fellowship in cornea from Shankar Nethralaya, and definitely a first is class 2. He has many awards in his name, that is Achievement Award of AAO 2013, PS Reshmi Endowment Lecture Award, Hyderabad 2013, IIR SI Gold Medal 2015 in Delhi and 2024 in Chennai. He has got a MM Joshi Oration Award in Goa 2017 and Dr. O. Gopalakrishna's Lecture Award at APAO Karnataka in 2019. So I definitely like to introduce a very interesting Dr. Rishi Swarup to have his words.
Thank you. At the outset, I'd like to thank the Vidarbha Ophthalmological Society for so kindly inviting me for their inaugural webinar. So the topic given to me is some challenging case scenarios of in refractive surgery. So I'll just share a few different cases and we'll be happy to discuss later if we have time. I'll just share my presentation. Are my slides visible?
Yeah.
Great.
Yes, sir.
Just 1 second. Yeah. So I'll just start with this case. It's a 35-year-old obese, nervous male. Patient was planned for intralaser LASIK. Right eye went perfectly uneventfully. And when the left eye was being done, it was a 9 mm 110 micron flap. Patient squeezed and the suction was lost during the side cut, which means just before the completion, last 3-4 seconds was done. So only part of the side cut was done in the left eye. So unfortunately, at that time, the recording was not there. So I have created an animation and you can just see that. And on the top right, that video is another representative image from a friend of mine, but not this patient's. So this is what has happened. The flap was created, and then as the edge was being cut, just short of the last, say about 30% of the 20% of the edge was left, and you can see that flap is dissected, but not the flap edge was not completely made because of the suction loss during this step. So how would one manage this case? It would be nice to have an interactive discussion, but I will just say in this particular case, would any of the panelists or any of the people attending would like to hazard a guess of what one would do in such a scenario? Dr. Somshila is here. I thought we'll wake people up before meeting time.
I would like to postpone it
Postpone it and do a surface ablation later, or
later on. Yeah.
any other opinions?
Rishi, do you have the circle software or not?
No, we do, but this was a intralace.
Oh, okay. All right. Sorry, I missed that.
Yes.
So if the flap did not bisect the center, I mean, it bisected the center rather.
Flap, the raster was done at the bed. Only the side cut, last 20% was left.
Then I would proceed 20%. So where at the side, you can just see that, but you could probably proceed, or best is to, I mean, the best bet is if it's the first time, you can just reschedule the case and be safe.
Yeah, so that's definitely an option. So at this point, two things came to my mind, that the flap has been dissected, only the edge is not cut. So one is I can take a scissor and cut it neatly. After all, we are cornea specialists. We just need to complete one edge, right? This edge. So that's one thought which came to my mind. And then I thought, it's okay, I've got a femtosecond laser here. And even though the flap bed has been dissected, only the edge part is not there. So what I decided was I'll do another side cut only mode. Femto has a side cut only mode in which you can only create the edge. That's what we did. We used the same cone, but made the flap diameter 0.5 millimeters long, shorter. So this 11 earlier, I made it 10.5. You have to make sure that you center well on the old flap so that the side cut will stay within the original flap and doesn't cut outside the flap. If it's decentered, that can happen. So this time I recorded. So you can see that the cone has the cut of the first laser. I'm trying to overlap that with the corneal cut so that it's well centered and reasonably well centered. And you can see what's the laser. Yeah, now you can see that outline of the first flap. So I'm just trying to center that. And then we basically go ahead and fire only the edge. As you can see within, I'll show you that again. We fire the edge and it actually highlights the outer flap edge as well. And then of course, you just need to make sure that you open the inner flap and not the outer one. So you have to make sure that you go into the right edge, not the outer one, but the inner one. It is slightly, not perfectly centered, but the entire edge of the new flap is within it. And basically, we went ahead and lifted that. I'll just run through this for some reason. The video is, yeah, so that's what we did. We opened the inner edge and then lifted that up. And then rest of the flap, the rest of the case was like a normal case. You just lift the flap up and complete the laser. So lesson learned is, of course, you have to tell your patients not to squeeze and blink, but that doesn't work always. If things go wrong or don't fret, there's always some solution. Like some people mentioned, it's always okay to come back another day and save the cone, don't discard it. So in this case, with the same cone or the PI, we could go ahead and do it. And undersize the flap and side cut only is a good option as long as you maintain the centration. So you have to sometimes think out of the box. So that's one case. Then this was another case, 23-year-old male referred to me from management from a colleague. Underwent uneventful both eyes LASIK with a microkeratome, pendular microkeratome. Early postoperative, the operating surgeon noted significant flap striae and performed the flap relift with ironing and repositioning. Subsequently, the patient developed a significant drop of vision with persistent photophobia, watering, and irritation. And this patient had to go back to US and had already delayed their ticket twice. And this patient was desperate to go back. So this surgeon called me saying that, do something. So when I saw the patient, this is what is going on. The inferior flap, you can see, is necrosed. There is some bullae-like epithelial, some bulge there in the lower part, and you can see that it's very thinned out. And if you stain, you can see that actually the inferior part of the whole flap is necrosed, and it's just hypertrophic epithelium at the bottom. There is no stroma there. So in this case, what would you do? There's a necrosed flap, and there's a lot of irregular astigmatism, and patient is also very uncomfortable. So I think most of you would do what I did. I decided that initially I wanted to just give the patient some comfort. I applied a bandage contact lens, give supportive medical therapy. And after a week, when the patient surface healed a little bit, that's when we decided to take him up. But you can see the edge is still staining like this. So we gave him another week of BCL. Vision was 618, but very uncomfortable. And this patient was now desperate to go back. So what we did was we explained the situation and explained that the residual refractive and irregular astigmatism and fuzzy vision was due to scarring. So we decided to go for a flap amputation under LA. So we just removed the epithelium, and once you remove the epithelium, you can see the inferior flap is completely gone. So you just lift it up. Make sure you debride the entire epithelium from the lower edge where it has covered the area of the necrosed flap. Otherwise, you'll have you may have a regular bed, and then you basically give a uniform opening, wash it, and then place a VCL. And you, of course, excise the flap at the hinge. This is how it looked 1 week after amputation. You can see the haze has actually come down quite a bit. And over time, it almost completely went away. And the patient actually got a very good outcome with a very small refractive error of about 0.75 cylinder. 6/9 unneeded improving to 6/6, and the patient was quite happy. Came to me many years after that also. and was doing quite well. So this is the pre-op OCT in the lower part and the post-op OCT after about a month or so. So lesson learned, in extreme cases of flap complications, sometimes it's perfectly reasonable to amputate and sacrifice the flap. The flap doesn't have too much of refractive effect and doesn't give too much tectonic strength to the cornea anyway. So don't hesitate to sacrifice if it cannot be salvaged. So this was, I'll just show one more case in the interest of time. I'm sure everybody wants to go and sleep. So it's a 28-year-old female, underwent LASIK both eyes elsewhere 4 months ago, presented with complaints of white spot over the black part of the left eye, associated decreased vision, dryness since 1 month. Vision in the right eye was almost planar, but left eye had a significant cylinder. Right eye flap was well opposed, but left eye was like this. So you can see this whitish islands of whitish deposits in the interface, and there was scarring all around it. And if you look carefully in the fourth image, you can see that the edge of the flap is again necrosed, as you can see, and there's some epithelial cellness which are going into the interface, which are those whitish pearly deposits with multiple extensions. And whenever you have epithelial growth, it lifts that area of the cornea. So you have steepening in that area, and then exactly above that, you have a compensatory flattening. So you get a lot of irregular astigmatism. And this is what was the cause of the high cylinder as well as the reduced best spectacle corrected vision for this patient. So what would you do? So one option is you just try and deal with the astigmatism by doing some sort of a topographic guided laser, but then you will not address the root of the problem. And there is a necrosed flap edge from which the epithelial cells can keep coming in. So in this case, because it was peripheral and the visual axis was spared, we decided to use YAG, and already the flap edge was little necrosed. So we thought YAG would help, and we can help to kind of cause some fibrosis there and close out the kind of opening of the fistula. So we did a couple of sessions, and the end point of the YAG is to get these tiny bubbles in the area of the epithelial cellness. So 1 month after the first session, you can see that reduced significantly, but still some epithelial growth was there. But you can see the topography had become more regular now, otherwise more of an irregular bow tie. And we did some more YAG laser to this, and then reduced further. And then 3 months later, you can see that topography is almost similar. Then we did some more YAG for the remaining cellness, and you can that completely scarred down the epithelial ingrowth, and the flap edge also completely closed. To our surprise, the iris had some spots on it. So the learning lesson for me was, even if you use very small settings, sometimes it can go through and damage the iris. So avoid using a YAG in the central cornea, stick to the peripheral cornea. Of course, we were using an Indian laser. Possibly if you use an international laser like Zeiss or Nidec, this may not have happened, but I can't be sure, 100% sure. So you can see at 3 months, it needed multiple settings, but we could take care of it. And an irregular cornea became fairly regular, and the patient's best corrected vision improved to 6/6. And one could always go back and do a topographic guided laser over this to improve the vision. Do I have time for one more case?
Yes, sir. Sure, sir.
Yeah, sir, proceed.
32-year-old female was interested in laser correction, underwent uneventful LASIK, and first post-operative day, the patient was very good in the right eye, but unhappy with the vision in the left eye, flaps well opposed, etc. So when I saw the autorev was showing a surprising error, a lot of mixed astigmatism, I immediately knew what has happened. There must have been an entry error. And it was such a high cylinder on the first post-operative day, and the eyes looking normal, something is wrong. So this is what is the mistake. The axis was mentioned as 170, but in the machine, what was entered was 70 by the technician. And of course, in a busy laser clean day, I overlooked this, and it was completely a mistake entry. It was a typo error which caused this problem. So, lesson learned, always check. After that, I make it a point to have a proper checklist and do like a timeout, just like we do in our regular OT, to check the refractive entry in the machine to make sure we don't make mistake. So we quickly relifted. We don't have to wait 3 months for this. We just go back, lift the flap, enhance. And this patient actually did so well that she preferred the second eye after this. We just relifted the flap, and this is the You can see a hyperopic ablation was done like this. And this patient actually did very well, as you can see the different snap. And patient got a planar result in this and was more happy in this eye over the long term compared to the first eye, which was not touched. So sometimes that also happens. So enhancements are perfectly okay. And retechnique rates have been reported to be as high as 37% in literature. And nowadays, with surface ablation, with advanced surface ablation, you can do surface retreatments over LASIK flaps, and they work very well. In fact, that's my preferred technique, especially for patients who had LASIK a long time ago or microkeratosis LASIK sudden like relief. I just do a surface ablation, and that works beautifully. And it doesn't compromise the tectonic strength of the cornea. So ideally, it's always good to enhance 3 months later, but you can do in the early if the eye is quiet and there's not much of an edema on the surface is healthy. So prevention is better than cure. So lots of checklists and at each level we must personally check the data. So I'll just end here, and I'd like to thank the Vidarbha Ophthalmological Society.
Those were really wonderful cases, sir. And the use of YAG for managing the epithelial ingrowth was very innovative. Though as you said, the entry of these lasers to the center can cause damage to the lens capsule. Okay, and now we are okay with to go with the session where we can have question answers from our panelists. I request Dr. Ajay Kulkarni to have some questions. If Dr. Saurabh Mundada, Dr. Subodh Purohit, any questions, please?
Nice presentation from all the speakers. So, a question to Dr. Rishi Swarup about this YAG setting. How did you manage the defocus, anterior defocus? How can you ensure that the laser spot actually hits the area of epithelial ingrowth?
So you use actually the smallest settings that you have in your machine. So I have the upper YAG, and whatever is the lowest, it allows I think 0.2 millijoules. That's what you put, and the smallest possible spot size if you have the option to use that, and you can choose an anterior defocus just like you use PI.
So actually, the laser is hitting that area and then passing across
No,
the
no,
cornea.
no. So ideally, we don't want it to pass. We just want
Yeah.
to hit the epithelial cellness and create tiny bubbles there. But in
Hmm.
my particular case, it had actually gone through. I've
Yeah.
not seen it in other cases. This was one of the
So
early ones.
has it something to do with the energy setting or the machine?
I think it has more to do with the machine because
Okay.
I know that a lot of my other colleagues who are doing have not seen this. So the Indian lasers um, deliver a little higher energy than we want to.
Okay. Okay. Thanks, Rishi.
Rishi sir, we need to hit the YAG exactly on the epithelial ingrowth?
Yes, exactly there, not around.
Okay.
So you see the white spots at that point. And
Okay.
you can actually try and hit the neck of the fistula from where the epithelial cells are going in.
The neck of the fistula.
Yes.
Okay.
Rishi sir, hello.
Yes.
Am I audible?
Yes.
Sir, I would like to ask if you have got a free flap and if you have not done a pre-op marking, how would you identify the upper surface and the lower surface?
So that you can do with stain. You can put fluorescein. Chroma will stain with fluorescein. So you can use that.
If you lose this flap, after how many days the reepithelialization takes place if you put the BCL?
Just like in a PRK, 4 to 5 days.
Okay.
Yeah.
So I would want to ask, in one of the case I experienced similar scenario some few years back. Like in cases of this amputation, you say one of the option can be amputation whenever you can't save the flap. Do you see very deep scarring very often? Or do you have number of cases in this scenario?
No, I've only amputated one flap till now. That is the one I showed you. But why should you have scarring? If you've had some scarring already, that will persist. But in my case, actually, the scarring came down once the inflammation was taken care of. What I thought was scarring was actually just some haze. It actually came No.
Sir, in your practice, out of 100, how many, as a percentage, how many you do surface ablation and you do LASIK nowadays?
I
Like
used to
many
do
of
a
us
lot
have
of
shifted
surface
to.
ablation earlier, almost 60-65%. Now I
Okay,
think in my practice it has become only about 20-25%, mostly smile.
great.
So, for Dr. Anupam Bagri, I wanted to know, while managing the chemical injuries, there are many readily available amniotic membranes are available, which are dry in form. What is your experience using a dry and wet amniotic membrane? And like, which one is your preference?
So to be frank, never use dried amniotic membrane.
Your voice is not good.
Yeah. So I have always used. Am I? No.
No.
Please come close to mic. Come close to mic.
Yeah. Yeah. One second.
Yes.
Yeah. So is it better now?
Yes.
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 Yeah. So I have never used dried amniotic till now. I have always used wet amniotic only. So I will not
Ranges maybe.
share with
Video.
No, not Anupam. We are not
Anupam, can
able to hear
you
it.
put your video off?
Yeah, I have
Your
put
video
my
off.
video off, sir.
Okay.
You have to come closer to the device.
Okay, okay. Is it better now?
Yeah, stay there only.
Okay. So I have never used tried amniotic membrane.
No,
I have
no, no.
always
We are
used the
still
wet
losing.
one.
No. Anupam, we are not able to hear you. I think you should join with some other Bluetooth device or phone
Okay,
directly.
okay, okay,
Or you
okay.
can
But
type your reply in the chat box.
okay, okay.
So you can take some other question in the meanwhile. Dr. Saurabh had raised his hand. Dr. Saurabh, you want to ask? Dr. Saurabh?
Pankaj sir,
Yes, sir.
Sure.
I'm allowed to ask questions.
Yes, sir. Please.
Can someone, Dr. Ajay sir, Dr. Saurabh sir, can you throw light on using bandage contact lens after PRK? Ajay, what type, what size, which company?
You can repeat the question, please.
I got the question. Basically, you know that the commercially available bandage contact lenses, we have a flat fitting and a steep fitting lens that is 8.4 and 8.6 base curve. So,
Yes.
what is important is the curvature because we are creating a flatter corneal profile after ablation. So,
Yes.
we need to select the lens accordingly. Secondly, the material and the oxygen carrying capacity of the material, which is the DK value, that is how much amount of oxygen passes through a unit volume or unit area of the lens. So any lens which has a DK value of more than 80 is good enough, or any lens which is approved for 1 week extended wear, that is the best option. Company, you can have a choice. We have good companies like Bosch and Lomb, Alcon, and uh, J&J. Any of the lenses which you prefer, you can use that.
How do you select amongst 8.4 or 8.6?
Yeah, as I said that when the corneal profile becomes very flat after the ablation, if you are putting a very flat fitting lens or against a very steep fitting lens, we have
Okay.
to give some space for the epithelium to regrow. Because many
Yes,
times
sir.
you will see that the epithelium is not growing in the usual way from the periphery to the center, and you will see the walls trying the
Yes.
epithelial cells are going haywire, and sometimes you will see that grayish area. Even you can see that epithelial healing line, or which is called also a pseudodendrite like picture. So if you see that the epithelium is not completely healed, do not remove the lens. Don't be in a hurry to remove the lens in 3 to 4 days. You can continue the lens wear at least for 6 to 7 days and then remove the lens. So we know that it is being used for bandage, so that should be that the lens should be serving the purpose of bandaging the surface.
Okay, sir. Thank you.
Any other input from the panel or from the speakers
Yes.
about the BCL? The other question regarding BCL is, would you like to use a BCL which is soaked in NSAID to reduce the post-op pain?
Basically, we should, I mean, at our center, we are not encouraging this thing because this thing, our counselor has counseled the patient that pain is there. So it's very dangerous to use any solution on the ablated cornea. So, I mean, we discourage at our center to use any contact lenses soak in any solution.
Yeah, we have other options of managing the pain. So the painkiller patch or the diclo patch seems to work very well.
Yes, we are doing the diclofenac patch, which is available in orthopedic surgeon. So we just put just before half an hour before the surgery, and we started NSAIDs day before the surgery. Topical drops.
So I would just mention that refrain from using any locally made cheap bandage contact lens, because the purpose here, as I just mentioned, that you should be using a standard product. Should not land up with trouble because of the lens itself after doing a good surgery.
Yes.
I would also recommend that we use a bandage contact lens rather than a low-powered, trial lens.
Yes,
Those
sir.
are more comfortable on the eye, and also they don't induce a refractive error.
Yeah.
Okay.
Rishi sir, if the patient of minus 2.5 of spherical comes to you,
yes, sir.
So what would be, choice of procedure for you for PRK or lenticulex?
If everything is suitable, I will go for a smile, sir.
Okay.
My procedure of choice, if the topography is perfect and patient's affordability is there. But otherwise, all would work. Surface ablation is also great for such a low refractive error. Chance of haze is also less.
Yes, sir.
So, yeah, everything works. But my personal choice is now lenticule procedures.
So in which cases you would not do a lenticule?
I don't have Smile Pro, so any patient with astigmatism more than 1.5, I don't like to do Smile. Other than that, most of the cases are whichever is suitable for femto LASIK is suitable for Smile also. So, because if your cornea is thin and all that, you can't less than 500 microns, you can't do either a flap or a cap procedure.
Yeah. So that's very important take-home message, because many people think that in a smile can be done in any case. So that's very important to understand.
Yes, the inclusion criteria are pretty similar.
Yeah.
In fact, I would say smile, the inclusion criteria has to be even a little more like the perfect case. No, not high stigmatism, patient profile also, because the patient generally ascribes a better result with a more expensive surgery. So there.
Also, the cap in Smile is slightly thicker than the flap in femto LASIK. So
yeah, it's a tissue hungry procedure. Yeah, I know.
Yeah, so your bed will be a little thinner.
Yeah.
Somshila ma'am, I have a question about using steroids in a very younger children. So when we are using stronger steroids in younger children, do you consider the systemic effects of those steroids and how to take decisions about it?
In the case of young children, I prefer not to use topical steroids because they can be iatrogenic, and you certainly don't want to develop cataracts in these patients. So I'd rather use a short course of oral steroid. The role of oral steroids is like a bridge therapy till my other agents can start working, and to get rid of that cycle of frequent eye rubbing, missing days at school, and a lot of trauma that the entire family goes through when these children come with that severe allergy. I'm talking about very severe allergy. And the dose is not a very high dose. It's more of between a sort of not an immune suppressive kind of dose, but more of an anti-inflammatory dose. It's about 0.5 milligram per kg. So they can use it for 2 or 3 weeks and then start stepping it down. And then the other agents start working. So this is usually the case in sort of moderate cases of VKC in pediatric patients.
Dr. Somshila, there's a publication from Cyan which advocates long-term use of oral steroids in pediatric
Actually, no. So the group that whatever we have published, it does not advocate long-term use, but not more than, so it in fact advocates longer-term use of oral immunomodulator therapy. And our go-to was usually cyclosporin, but now that with oral tacrolimus is also available, so that's another therapy. And because these are a little bit more expensive, so we can use methotrexate, which is a cheaper alternative and very safe in pediatric patients. So these are the extreme cases, the kind of cases that I showed you. These are not the sort of so-called run-of-the-mill or usual cases, which can be any case that can be managed topically. So by all means manage. And all the other, in addition to all of this, we also advise avoid allergens, avoid eye rubbing, cold compresses. So that's a large part of our therapy.
I have a small question / comment.
I'm
Since
feeling good. I thought everything was about refractive. So I also put on my video because I also do refractive surgery. But I'm feeling good that I'm getting some questions. I'm
I
being
have a
grilled
question
by
for
the
you.
co-speaker.
So I have lately been using Liftigras for
Yeah.
adult VKC, and it seems to be working beautifully, actually, better
Okay.
than cyclosporin. And of course, it may not be as effective as tacrolimus, but tacrolimus sometimes patients don't tolerate; they have burning, etc. Liftigras seems to be tolerated much better. So, have you any experience with these? And especially in pediatric cases, I've not tried it, but adult, it does seem to be working quite well.
Okay.
Yeah, technically speaking, conditions where cyclosporin is likely to work, liftigras should work.
Yeah, that's
So, and
And you can use
question
it
to
along
Dr.
with.
Somshila. Yeah. You just mentioned that you won't like to use topical steroid in children. So, what is your age cutoff? After which age you would be comfortable giving steroids topically with severe VKCs?
So I said that I won't be comfortable, but I do use, of course, because nothing else will work. And with careful monitoring the intraocular pressure. So those patients, I may give a supranational steroid injection for these patients where, or I just give a bolus steroid, like a 10 milligram tablet for say 7 days, 5 days, 7 days. That also works well. And then, of course, I'm saying that we do due diligence. So we always have a buy-in from, we have a physician or a pediatrician and make sure that the child doesn't have concurrent infection. Very often they have frequent cold and URTI. So to rule out all of these things, we don't want to
Yeah.
make that. With due diligence, we start this medication. If I'm not able to use oral medication for these reasons I mentioned, then I will start topical steroids. The age doesn't matter. But most of the time, the youngest age you might see is maybe, it's very, very rare to see somebody less than 7, 4 years or something. It's very rare. Those children would have either hyper IgE syndrome or they would have atopic dermatitis or some other condition. So VKC alone, without the systemic other allergies, is more likely in an 8-year-old, 9-year-old, where you can manage, you can check the eye pressure and so on.
I found the highest strength loteprednol be very useful in some of these cases,
Yes,
which
yes, 1%.
to
Yes.
say fluoromethalone and all, so that kind of just gives a little more than loteprednol conventional and less than prednisolone. And also, I found using ointments of loteprednol or fluoromethalone at night very effective actually in some of
Yes.
these cases.
Yeah.
Stays all night.
Even the propensity of rise in intraocular pressure, even
Yes.
with 1% loteprednol, I have not seen. I've been using it regularly. So I'm quite comfortable using 1%.
So the way to look at it is that to retain the steroid in the eye. So we're giving oral steroid to retain the steroid in the eye. What you're saying is giving ointment or the drops, because the child will just close the eye, and it's such a nightmare for parents to instill drops in the patient's eyes.
Yes.
So my question for Dr. SS or Dr. Kulkarni sir. Sir, for general ophthalmologists who are attending this webinar, so how would you decide upon the steroid? So be it loteprednol, low strength, full strength, be it fluoromethalone, diaflufenacin, there are so many options now available. So like just a brief guideline for choice of topical steroid in VKC patients or allergy patients.
Shall I go or it's for Ajay?
Yes, madam.
Yeah, ladies first.
So my philosophy is simple. VKC right away, right off the bat, is not a sight-threatening disease. So we need not treat it like the way I treat uveitis or the way I treat some very severe diseases. So I try to use the least potent strength steroid with which I can get control of allergy. For mild cases, I might just use, 1 or 2 weeks of steroids if the patient has a lot of eye rubbing. For moderate cases, maybe a slightly longer course. When I say weaker strength, so it would be loteprednol, even 0.2%, 0.5%, or it could be fluoromethalone. These could be the topical steroids that I would start off with, and then I keep adding. So I've seen many doctors, they give loteprednol as well as mast cell stabilizers and lubricants and some ointment at bedtime, all at the same time. So nothing is going to work, or the child is not going to let you put it. So if you're giving a steroid, you don't need to give anything else for the time being. Mast cell stabilizers work for prevention. So wait till the eye comes under control. And then as you withdraw the steroid, you can add the second drug. And off late, because mast cell stabilizers are less and less available, so you have the other medications that are there, olopatadine and so on. We're forced to swap, instead of mast cell stabilizers, use those. And finally, the ointment at bedtime, as Rishi mentioned, we still continue to use tacrolimus ointment. We routinely ask them to put it on their eyelids, on top of the eyelids, because children don't like to put it in the eye. We have to trick them if you want to put it in the eye.
Yeah, I would agree with Dr. Somshila. Only one point, one switch steroid which I will not use in children is the dexamethasone, because the cataractogenesis and IOP rising activity with dexamethasone is far, far better than all other steroids. I mean, far more than all other steroids.
Right. Right. Ma'am, what about the battery of investigation, or which type of investigation in cases of VKC you would like to see when starting any type of medication, especially like your like IG syndrome you are talking about, or is there anything specific about those kind of blood investigations?
Are you saying that for VKC management, or because I'm starting toxic drugs?
Because you are talking, no, VKC management.
So for diagnosis management, nothing really, unless I'm suspecting hyper IgE syndrome or some other condition, which is why the patient has VKC. Otherwise, there is really no systemic investigation that will help us manage the patient better. It is the duration of disease, the severity, whether it's mild, moderate, severe, and the findings that you see in the patient. Does the patient have shield ulcer, or is it limbal form, or is it the palpable form? So this is what we need. We don't, some people do the sensitization and all of that, but I've never been a big fan, because not really.
Yeah, that is what I was about to ask. That about sensitization, no need.
In my opinion, there's no role of that, but I know people do that and they do say that it helps. So yeah, we're open to varying the thought processes.
Okay.
As far as supratarsal injection is concerned of steroids, can we repeat the injections, and for how many times? If patient is responding to the supratarsal injection of steroids.
If we're repeating it, it means that the child has, assuming it's a pediatric patient, because in an adult patient, you can just ask them to use Pred-4 eye drops or something. But that means that you're not able to break the disease cycle, or the child goes back to the same milieu, maybe doesn't use medications in between. So I want to control the disease better. So this is exactly the indication for me to switch to oral medication. So I would switch to oral immunosuppressive medications for a short while in a lower dose. The doses we use for them is much lower than what is used by, say, people who have undergone transplants or something like that. There, the doses are very high. So here we typically use about 1 milligram per kg body weight, so which is much safer. And of course, we do monitor for some certain side effects like renal function test, liver function test, blood counts. All of these have to be done.
It is good to involve a pediatrician in management of these kids, because they are better placed to look for issues regarding especially the side effects of long-term steroids and the immunosuppressives. As you rightly mentioned, methotrexate, I am also a big fan of methotrexate. Very well tolerated across all age groups. You hardly see any great issues regarding the side effect of methotrexate.
But again, don't use oral steroids for a longer term.
Yeah.
Ma'am, do you lower your threshold for collagen cross-linking in patients with VKC and keratoconus, or is it more or less the same as any other patient who doesn't have VKC?
For patients with allergy, my threshold is very low. As soon as I control the allergy, I provided that the keratoconus is obvious and it's a child or a young adult, I'll definitely go ahead and upfront cross-linking.
So no waiting for progression and all that.
Yeah. I wouldn't wait. I'm sure most people wouldn't wait.
Yeah, but make sure that the surface inflammation is well controlled before you take the patient for surgery.
Yes, sir.
Okay, I think that has covered most of the questions, and that was a really interesting session. And I would like to now hand over to Dr. Shada to give a vote of thanks.
Thank you, sir. At the outset, on behalf of the VOS Executive Committee, I would like to thank the national faculty for today's webinar for sparing their valuable time and enlightening us on the essential topics of eye allergy and case-based refractive surgery. I would also like to thank our VOS faculty, Dr. Shirish Thorat sir and Dr. Anupam Bagdi, for beautifully explaining the basics of refractive surgery and the nuances in the management of chemical injury. I would like to thank Dr. Deepak Nilawar sir, Dr. Vinod Adlakhia sir, Dr. Nitin Upadhyay sir for chairing today's session. Our panelists for today, Dr. Ajay Kulkarni sir, Dr. Subodh Purohit sir, Dr. Saurabh Mundra sir, Dr. Kavita Dangra madam, Dr. Prabhat Nangia, and Dr. Neha Rathi for bringing up the essential points in today's discussion. I also like to thank the moderators of today's session, Dr. Pankaj Lande sir and Dr. Anand Pasari for helping to create this program and the smooth functioning of the session. I also like to thank the Akola Academy of Ophthalmology for curating such a nice program for us this week. At the end, I would like to thank the Entod pharmaceutical team and the support team for keeping this program glitchless and helping us to keep this program a crisp one. Thank you and good night.
Thank you.
Thank you so much.
You.